Welcome and thank you for standing by. At this time, your lines have been placed on listen only until we open for questions and answers. To ask a question, you may press *1 on your touch-tone phone. Please be advised today's conference is being recorded. If you have any objections, you may disconnect at this time. I would now like to turn the conference over to Sevgi Arail. Please go ahead.
Thank you so much. Good morning. Welcome to our third lecture in the DSTDP ASTDA, Division of STD Prevention and American STD Association Prevention Science Series. If you remember, we listened to Jean Marazzo, and we then listened to Ward Case. And today, we are really lucky because we have Connie Celum with us to talk to us. It's difficult to introduce Connie. Some of us have known her for quite a while. Maybe she doesn't need any introduction because we have in the audience all people who read the literature. And if you read the literature, you don't need for me to introduce Connie to you. But I do have to introduce her, right? I mean, I do have to earn a living myself, too. So I have been researching Connie so that it doesn't end up being too personal an introduction. And I would like to tell you some characteristics which I have found in the literature, some things that have been said about Connie. And they go: vision, persistence, impeccable scientific integrity, commitment to her teams in the field and to her trainees, force of nature, scientific rigor, perseverance, empathy, sense of humor, and commitment to help others succeed. I'm not a jealous person. I'm not very envious, but when I read those words, I thought, I wish someone would say those about me too. And I'm reading them to you because I agree with every single one of them, 100%. You know, many of us in this group know Connie well from about a decade ago. I don't know how many of you were here then, but if you were, you will remember that Connie was our top choice for directing the Division of STD Prevention over a decade ago. Fortunately, unfortunately, I'm not sure. Perspectives would make a difference, so I'm not going to go there. But Connie chose not to come here, to stay at the University of Washington, and she went on to conduct and spearhead several landmark prevention, HIV prevention, transmission, acquisition, and disease progress trials, all of which made huge contributions to the field. I happen to know Connie even before you all got to know her. We discovered last night, it was early 90s, didn't we? But what I want you to know is I got to know Connie then because I was directed to her as an expert in health policy. Now, it turns out now health policy is a major priority for us, and we have many people working on it in the division. So in early 1990s, she was the only name I was given for, in the STD domain, people who are experts in health policy. Connie got her training at Stanford University, UCSF, and University of Washington. Currently, she's a professor of global health, a professor of medicine and epidemiology at the University of Washington, and she directs the International Clinical Research Center at the UW. She has received the ASTDA Achievement Award in 2011, and she has established an organization in Africa through which she supports education for girls. With that, I'm going to ask Connie to come up and educate us all.
So thank you, Sevgi, and I don't want to disappoint you all. That was a very, very nice introduction, and probably I'm going to disappoint you not meeting your expectations. But one observation I will make is you should not go to dinner with Sevgi the night before you give a talk, because she pulls out all sorts of information that afterwards you start thinking, oh, how is she going to weave this in? But she was selective. It's really a pleasure to be here. It was about almost maybe 10, 11 years ago when I was here looking at that job, and the reason why I said no was because I had this determination that I wanted to answer a question about herpes and HIV acquisition, and that ended up taking me on a long road that I'll tell you a little bit about today. So I think there's some important lessons, and it's one that it takes time sometimes to digest those lessons and realize that as much as we know, we still have much that we don't know. And hopefully at the end of the talk, I'll just give you a list of 5 of what I think are current priorities for looking at STIs and HIV. So I'm going to just give you a brief view of what we think we know about STIs and how they impact both HIV susceptibility and infectiousness in terms of both curable STIs and also herpes, and then try to tell you the story through the lens of what we thought we knew and what might happen if we intervened on herpes and potentially could reduce the risk with HIV, and tell you about several trials that a couple of which we did, and then end with current perspectives and priorities. And I think it's, I'm sure at CDC you see a lot of slides about STI prevalence in the U.S. as well as globally, and the data are not very recent or probably high quality from many parts of the world, but I think this slide is just to give you the general perspective that STIs are very common, and there's a really high prevalence in, particularly in Africa, where HIV prevalence is also a big burden. And I think you could start with the perspective of there is a lot of overlap between STIs and HIV, and so of course STI control is important to HIV prevention. We know that HIV co-infected people with symptomatic STIs, especially those who do not have viral suppression or not yet on ART, they should be a high priority. And it seems kind of like a no-brainer that STIs would be important to HIV transmission, both from a biologic perspective, by increasing HIV viral load, but also behaviorally in terms of people who are acquiring STIs are often having more partners, and so they may transmit both HIV and STIs. And then I think because people seek, when they have symptoms, they do seek care for it, people with STDs are a common entry point for identifying HIV-infected persons and delivery of prevention services. So there needs to be an integration of STI and HIV services. So that's sort of from a basic set of principles. But then when you really start drilling down and saying which STIs, where would you focus, it's important to disentangle this more. And I think I'm a clinician as well as an epidemiologist, and I think it's really important to think biologically about these kind of pathogen interactions. So when you think about STIs and HIV infectiousness, there are multiple ways in which STIs might increase infectivity. With herpes and genital ulcer disease, it could be through mucosal disruption. They also recruit target cells for HIV, CD4 cells in particular, at the site of the mucosal epithelium, and that's where HIV transmission occurs. They cause pro-inflammatory cytokines to be increased in amount. And there are multiple ways, basically, where you could say that STIs, one would think, would increase infectiousness and also susceptibility in some of the same ways. Mucosal disruption creates a portal of entry if you're HIV uninfected. You recruit target cells, so you're going to be more likely to get infected with HIV with the same exposure if you have a concomitant STD. So think about the mechanisms, because I think in the end, when we come back to this, I think what we'll realize is that we probably need to understand some of these mechanisms better before we can come up with better interventions. So Ashley Haas had a nice review in Nature about 2 years ago where he tried to describe what they've learned from animal models about HIV acquisition and how it really happens quickly, that there's this founder population of viruses, and if you have activated CD4 cells, at the site of the mucosa where HIV exposure occurs, that things take off really quickly. And in the macaque model, you get infection that goes from the mucosa to the systemic lymph nodes and systemic circulation within a week. So if you have something that increases the amount of activated T cells there, that will facilitate the transmission. So if you move from the biologic perspective to an epidemiologic perspective, I think it's useful to go through that same process and thinking about HIV acquisition and transmission using the Bradford-Hill criteria, which were established when they looked at lung cancer and smoking. And it's basically looking at how strong is the association, how consistent is it across multiple studies, do STIs come before either HIV acquisition or transmission, how specific is the association, and is there biologic plausibility? Well, we've just talked about the biologic plausibility. And I'll show you some of the data from epidemiologic studies about STIs and HIV susceptibility and transmission. And basically, most of these criteria are met. So some people, like when we proposed the herpes study, thought, well, why do you need to do an intervention trial? The data are really strong, and we should just be moving on these data. But the story that I'll tell you will convey it's not so simple. So if you go back to the earliest studies in the almost 30 years ago now, there were strong data that came out of Nairobi, where some of the first studies were done, that looked at, in the setting of an explosive HIV epidemic, where 85% HIV prevalence in sex workers, really staggering. And in the STD clinic, they looked at men who had exposure to sex workers, and they found that if the man had genital ulcer disease and was uncircumcised, that was very strongly associated with HIV seroconversion after single sex worker exposure. So some of the earliest data date back to 30 years ago. At that time, we didn't have great herpes diagnostics, and most of the genital ulcer disease was due to chancroid and syphilis. But this sort of started people on the trajectory of thinking, if we could intervene, it's much easier to, at that point, to think about STI control than people weren't quite ready to think about circumcision trials. So this launched a lot of effort to look at STI intervention. About 7 years ago, Jeff Garnett and colleagues had a nice paper in STD where they looked at this point over 30 studies that were longitudinal. So when you think back to the Bradford-Hill criteria, right, one was, did the STDs come before HIV acquisition? And they broke down the studies into whether they were genital ulcer disease or non-ulcerative STIs, and looked at the relative risk of HIV acquisition if someone had a genital ulcer disease or an inflammatory STI before they became HIV infected. And basically, it looked like there's a little greater risk of HIV seroconversion if you had genital ulcer disease, and it was similar for herpes, syphilis, and chancroid, and a little less if you had gonorrhea, chlamydia, and trich. And since then, there have been a number of studies that have been published that also, I think, have teased out that there may be important risks with vaginitis, and both BV, some studies looking at candidiasis and trich. And these data came from a Mombasa cohort where they had a large number of seroconversions over 2 decades, and it looked like it was basically in the 1.5 to 2-fold increased risk with HIV if women had vaginitis. There's also a paper around that same time that took multiple studies and did a nice meta-analysis and came up with a similar point estimate of about a 60% increased risk if women had VV. And again, I think this is a good example of trying to really take that observation and think biologically, why might VV increase HIV risk? And there are multiple mechanisms. It could be hydrogen peroxide, which, interesting. Can I get rid of this little thing? Cancel. Sorry. Hydrogen peroxide, alkaline pH, cytokines, and perhaps even direct stimulation of HIV expression by BV-associated bacteria. So I think for the future, as we come back to thinking about what interventions for what STDs, we need to have a better understanding in the cases like BV about which mechanisms are most important that will help target the intervention. So stay tuned to the BV field, because I think there's a lot of work going on now that might shape future interventions. But in that paper that I mentioned a couple of slides back by Jeff Garnett's group, they did a really nice job, I think, at trying to understand why is there such variability in some of these studies. And they, I think they thought that the data were pretty strong for STDs increasing HIV susceptibility, but there was really a paucity of data at this time, 7 years ago, about the impact of STDs on HIV and infectiousness in terms of direct observation. And part of that is it's so hard to do those studies. When you think about it, you need to have HIV-supporting couples, right, where there's a high enough prevalence of STDs, and where you follow them longitudinally, you can really say the STD preceded the HIV transmission. And many of the serodiscordant couple cohorts, and there aren't that many of them at the time they published this, had low prevalence of STDs. So there was less clarity about how important STDs were for HIV infectiousness. And so they made a nice analysis of this and said that really you do need couple studies to try to look at this, but some of the limitations are it's hard to get the couples who are at highest risk of incident STDs in these HIV-discordant couple studies. So then, as a result, people have relied on surrogate markers in terms of looking at STIs and HIV infectiousness. And Mike Cohen, almost about 25 years ago, had the first paper in Lancet, not 25 years ago, 15, right? Anyway, about the effect of urethritis on genital, on semen HIV levels, and showed that it went up quite a bit with urethritis and went down after treatment for urethritis. So there are now 39 studies that were analyzed about 4 years ago by David Lewis and colleagues in an issue of STD, where they did a nice meta-analysis. And without going into the details, I think if you look at the histograms and the force plots here, you'll see that there's quite a bit of variability, and some of these are incredibly small studies with very wide confidence bounds. So I think you can see just at a glance that there's different effects of STDs on genital HIV shedding. But if you group them by type of STD, it appears that urethritis and cervicitis, the inflammatory STDs, increased HIV shedding by threefold. When you looked at those where they were able to dissect whether it was gonorrhea or chlamydia, there was a more modest effect of those two bacterial pathogens, and that there was less evidence for an effect of early syphilis and vaginitis on genital HIV shedding. So all that literature over almost 25 years of that time relied on a surrogate marker of genital HIV shedding. How well does genital HIV shedding predict HIV transmission? Turns out, last year we published this paper from our HIV discordant couple study. It predicted very strongly that the higher your level of cervical HIV or seminal HIV really predicts the risk of HIV transmission. But this is the first time after all those years of publications of surrogate markers that we really had validation that that was a good way to look at the effect of STIs on genital HIV shedding and therefore infectiousness. So moving from the biologic and epidemiologic observations to actually trying to test the hypothesis that doing something about these STDs would have a benefit for HIV prevention, there have been a number of studies, about 9 altogether, and I'll first talk about those that focus on curable STIs. And they started in the 90s, where they took, in some cases, high-risk populations like commercial sex workers and Ivory Coast, or community-level general population studies, and tried to intervene either in the case of sex workers with monthly exams with presumptive treatment, or either syndromic management or mass STI treatment at a community level. And one also there's another study of sex workers in Nairobi. So they represented everything from high-risk populations like sex workers to the general population. And only the first of those trials, of those first 6 trials that were focused on bacterial STIs, showed an effect. And it was about a 40% reduction in HIV in Mwanza on the shores of Lake Victoria in Tanzania. So for those who are younger in the audience, this spawned a huge process of trying to dissect what worked in Mwanza that didn't work elsewhere, and a lot of debate, and it seemed like there was one consultation after another trying to make sense of it. But it really disappointed people because it seemed like it would be so obvious that you should have an impact on HIV if you treated STIs. So in all these consultations, people thought about, well, maybe it has to do with who's having sex with who, how risky the behavior is, the prevalence of STDs, where they are they in an early phase of HIV or a more mature phase, how well they achieved coverage of STI treatment with their intervention, and a lot of discussion about, well, but none of these trials focused on herpes. And I didn't show you the data, but when they went back and did testing from some of the population-level interventions, it's clear that herpes is very prevalent, 50, 60% in some of these populations, and much more prevalent than bacterial STDs. So one conclusion is maybe their hypothesis was right, but they focused on the wrong STDs. So it created a lot of, I think, angst and some confusion about whether you could really say, based on these intervention trials, that STDs had a causal role in increasing HIV susceptibility. So now I'm going to shift and tell you about my long and winding road, and felt like this was kind of looking through a looking glass dimly as I look back on it, that it seemed like taking the data that I just showed you, which was, good but not totally consistent in terms of different STDs and HIV acquisition and transmission, the data seemed even stronger for herpes, so that's why we focused on it. And really some of the earliest studies domestically show that herpes is an important co-infection with HIV and an important risk factor for HIV acquisition. And it seemed like herpes would be a logical STD to focus on because it wasn't just a short infection. People have herpes for life. And the epi data, and I'll show you this on the next slides, really suggested that herpes reactivation increased both HIV susceptibility and infectiousness, and some early studies around the time that we had monotherapy for HIV suggested it actually had an impact on disease progression as well. And we also knew that this synergy also was truly bidirectional, and that people who had herpes and HIV who were co-infected also had more frequent reactivations of herpes, and so they were also probably more infectious for herpes. So these two viral epidemics truly did synergize and build on each other. So there are more studies that have been published since this review in 2009. There are, by my count, well over 30 studies now. There were longitudinal studies that adjusted for age and sexual behavior, because obviously sexual behavior could be an important confounder. And the bottom line is it suggested that having herpes at the beginning of follow-up in these cohorts increased the risk of HIV acquisition by anywhere from 1.5-fold in studies of gay men and sex workers to 2.5 to 3.5-fold in general populations of heterosexual men and women. And again, the biologic plausibility was there, that we had a number of studies that suggested that herpes does recruit target cells, studies that were done in Nairobi by Rupert Call's group, which showed that there was an increased recruitment of CD4 cells that were activated and expressed CCR5 at the cervix. And studies that were done by my colleagues in Seattle suggested that we totally underestimate how frequently herpes reactivates. But if you do PCR where people just swab themselves externally daily, that you can show that herpes reactivation is 1 out of 5 days. And most of those reactivations are asymptomatic. So they're shedding, and when they're shedding, they're recruiting HIV target cells. So it seemed like the obvious thing to do was we had a generic drug. Acyclovir had been used in 40 million people when we started these studies. It was cheap, $40 a year at the lowest cost for 400 milligrams twice daily. So it seemed like such a relatively simple intervention, very well tolerated. So there were 2 trials, one done by the London School with Debbie Watson-Jones, where they went in Mwanza again near Lake Victoria. They recruited high-risk women, and those that were HSV2 positive, seropositive, were randomized to 400 milligrams of acyclovir or placebo. And their results came out in 2008, and people were really surprised because there was no sense of an effect. It was totally flatline. The hazard ratio was 1.1. So people were really surprised and disappointed and puzzled and thought, well, maybe it's because they had quarterly visits. These are high-risk women. They were mobile. And only about 3/4 took more than 3/4 of their tablets. And acyclovir has a very short half-life. So that adherence level, maybe that explains the lack of effect. We were in parallel doing a study in high-risk gay men as well as women from the general population from 3 sites in Africa and 3 sites in Peru and 3 sites in the U.S. And it was about 4 times as large. It was about, what did I do? Sorry. It was about 3,200 people overall. About 60% were gay men and about 40% were women from the 3 African sites. And an identical design, same dose, acyclovir 400 twice a day or matching placebo. We had monthly visits, so we were able to ensure adherence was higher and had higher drug adherence. But still, we had the same result, that there was a total flatline. There was no evidence that suppressive acyclovir reduced HIV acquisition, even though it did reduce genital ulcer disease. It wasn't water. I mean, we did achieve a biologic effect. We did reduce significantly the incidence of genital ulcer disease, but had no effect on HIV. And when we presented these results, the adherence debate became less of a consideration, and people were really puzzled, like, why is this? So one of the things, if you've never done a clinical trial, is, it's hard to describe what it's like when you open this envelope and you fold it different ways and think, this can't be right, and why is it? Because it's so hard to have equipoise while you're doing this trial. You start to believe the hypothesis more and more, because you probably gave 100 talks during this time about the rationale, and so more and more you think, of course it's going to work, and then it doesn't. So why? So the first question is, maybe we made some wrong assumptions about the drug, and maybe we didn't know enough about the pharmacokinetics in this population. So we did go back, and we worked with Craig Pinter at Hopkins, and found, to our surprise, that the levels of acyclovir we achieved were lower in these African women than past PK studies in the U.S. and Europe. And this remains an observation that we don't fully understand. So if someone's interested in doing drug PK polymorphism studies, there's, I think, still work to be done in this area to understand it. Was there something? These were healthy women. They were not malnourished. So we don't think it was that they didn't absorb it or they had other co-infections, but there's something about the drug dose we gave that didn't achieve quite the level we expected. However, we did also do an episodic GUD study to make sure that the drug, and same drug as used in the current trial, achieved a clinical and virologic response, and it did. So even though the PK data were a little bit worrisome, clinically and virologically it looked like it, genital ulcers responded just as we would have expected based on past data. But then someone did a really small study, and this is where it's so sobering. When you think about it, you spend all this money, 3,200 participants in a trial, and someone can do a study with 8 participants and shed light on the pathogenesis. And I'll show you this in the next slide. So Larry Corey and a doctoral student at the time did a really simple study. They just basically took people in Seattle who had herpes, and they biopsied them. And I'm not sure how well this shows, but in the green are CD4 cells, and in the red are CD8 cells. And those CD8 cells are specific to HSV based on the epitope mapping. And on the right, on the panel that says normal skin, that blue layer is the top of the epithelium, and these were biopsies taken during herpes ulcers. And you can just see how dense the infiltration is of these lymphocytes. And on the bottom panel are repeat biopsies. These are very motivated participants who came back and allowed multiple biopsies over up to 20 weeks. And you see that even though it's less than that top upper left panel, the inflammation persists for 20 weeks. And these are people who were on acyclovir suppressive therapy after they had that initial lesion. So when they actually counted the cells, there was a 10-fold increased density of CD4 cells compared to when a biopsy of the normal skin where they weren't having a reactivation. So it really suggested, yes, the hypothesis that herpes recruits target cells is totally right, but what we were wrong about was that by suppressing the virus, you don't quickly suppress that genital inflammation. And so the way we interpreted this is that basically it's kind of like you have a smoldering fire below the genital mucosa, and if you put this together with the fact that on 20% of days people are shedding herpes, basically they're chronically having genital inflammation that increases their susceptibility to HIV, and that we don't have a good tool yet, at least with the current drugs at those doses, to really suppress herpes. So that was a rather sobering study that came out about a year after our trial results. So our drugs clearly are not as good as we would like against herpes. What about herpes vaccines? And this has been a challenging area. As you probably know, it was only a couple of years ago that the HerpVac trial reported their results, where they did not see any efficacy with a glycoprotein-based envelope glycoprotein GD herpes vaccine, which did not show any efficacy. And this was very disappointing because that same vaccine had been in subgroup analyses in earlier trials, which suggested that maybe in the setting of not having either HSV-1 or HSV-2, it might have efficacy, but it was really pretty flat. So we clearly need to not abandon this area. We desperately need a herpes vaccine. I didn't show you all the epi data, but you're probably familiar with it. There are populations where the prevalence of herpes is 50% by the time a woman is 25. And in HIV-infected populations, it's 80 to 90%. So we need to try to push both academics and pharma to continue to work on new targets. As I understand it, right now the field has shifted to thinking about therapeutic herpes vaccines because of the disappointments in a preventive vaccine. So we need to keep our eyes on this and try to get our basic science colleagues to continue to look for new targets. However, it's not all dim news. We were very surprised and delighted when the Caprisa trial of 1% tenofovir gel in the Durban area of South Africa showed about a 50% reduction in HSV-2 acquisition. And this was in a context where they showed about a 39% reduction in HIV, so it was even a little better than their HIV protection with pericoital dosing of tenofovir gel. But I want you to note how high the incidence is in the placebo arm. So the annual incidence was 20% of herpes. So just, again, to point out, these were women, average age was 21. That is an incredible risk of herpes. The HIV incidence in the same population was 9% in the placebo arms, so it was twofold higher. So let's hope that we'll get further good news about tenofovir and herpes. People are interpreting this as, well, it's because you get such high tenofovir levels with a gel application. But we will be presenting some data from our oral prep study that's also showing some signal. So let's hope that with high adherence to oral Truvada, that there may be also some herpes protection. So let's shift from all that was about herpes and HIV susceptibility. Let's talk about herpes and HIV infectiousness, and again, review the epi data and the biologic plausibility before we talk about the trials. So I mentioned multiple studies have tested for herpes in HIV-infected populations, and the prevalence is 70 to 90%. By the time someone acquires HIV, most have already acquired herpes. And herpes reactivation is even more frequent. It's about 1 out of 3 days in an HIV-infected person. And during reactivation, studies dating back to the 90s showed that you surprisingly not only increased genital HIV shedding, but actually in the systemic compartment and blood plasma, the levels of HIV increased. And the thought was that might be because herpes proteins actually directly upregulate HIV replication, which has been shown in the lab, as well as indirectly through pro-inflammatory cytokines. We had a review this year where we tried to put together all the intervention trials that asked the question, how much could you reduce plasma and or genital viral loads by suppressing herpes? And all but one study showed that you could reduce viral load. On average, it was about a 0.3 log reduction. And I'll come back to the one at the bottom, which is a study we just completed in Kenya, which showed if you really push the dose, more like zoster dosing of valacyclovir, you could really get a much higher effect. But most of the studies use either acyclovir 400 twice daily or valacyclovir 500 twice daily, and we're in the 0.3 log reduction. But what no one knew at this point was, is that enough to have an effect on HIV infectiousness? So with a leap of faith and funding from the Gates Foundation, we undertook a trial to ask this question, and we did this in parallel with the other study that I just told you about, HP1039. And this is where I really had an immersion in clinical trials and in Africa, because we found we needed 14 sites, and we worked in 7 countries, and these are both urban and rural sites. And we took a leap of faith and worked with half the sites who had never done a clinical trial. To do your first clinical trial with HIV seropositive couples, it's not an easy trial. We had to work hard to really promote couples counseling and get men to be tested with their partners. But amazingly, through a lot of incredible hard work on the part of the sites, we enrolled 3,400 serodiscordant couples where the HIV-positive partner also had herpes and had a higher CD4 count than made them eligible for antiretroviral therapy at the time, and did the same intervention. We didn't know at this point that maybe the dose was on the low end. But we used acyclovir 400 twice daily versus placebo, followed the couples for 1 to 2 years, and our primary question was, does its reduction in viral load translate to a reduction in infectiousness? So our primary endpoint was the rate of HIV infection in the negative partners. But we were also interested in disease progression, so we looked at a composite marker of disease progression. And what we found, and this was like about a year after the disappointment of HP1039, is that we saw, again, a flat line. At least this time the hazard ratio point estimate was less than 1. We celebrated after about 1 second. And it was in the context, however, that we did reduce viral load, and about as much as we would have predicted, about 1/4 of a log. So people took the drug, by and large, enough that they reduced their viral load. And we had a 73% reduction in genital ulcer disease in the acyclovir arm. So again, there was biologic activity, but it wasn't enough reduction in viral load to translate to reduction in transmission. We celebrated a little longer than 1 second the fact that we did get some signal that herpes suppression reduced disease progression. We had about a 16% reduction overall in the progression to CD4 less than 250 ART or death, and a little higher than that among those who had a higher CD4 greater than 250 at entry, about a 19% reduction. So it was interesting when we tried to meet with stakeholders and say, what do you think about this? People thought, oh, that's interesting, but even though acyclovir only costs $50, $60 a year generically, it was not compelling enough to convince people that we should be using acyclovir to delay disease progression. When we go back to what we found in terms of transmission, we took these data from those 3,400 serodiscordant couples and tried to ask the question, so how we powered that study looking for a 50% effect. And if there's been one lesson over the last years in HIV prevention is that's pretty optimistic. And most trials, other than the male circumcision trial and a couple of the PrEP trials, have not hit that bar. So, you know, these trials have to be large to look for less than a 50% effect. To have reached a 50% reduction in transmission, we would have needed to have seen a 3/4 log reduction in viral load. So when you start thinking about this, there's a lot of interest in could you identify other co-infections where you could achieve this kind of 3/4 log or greater reduction in viral load. And when you think about it, it has to be an intervention that will have consistent, sustained effect. So it's hard to imagine that for most bacterial STDs, we're going to have that effect for long enough that you would actually see a reduction in transmission. So I think we learned some things, again, from analyzing the data we had from this trial about what the bar needs to be when you think about reducing infectiousness. You have to have a pretty big effect. So we asked the question, the Gates Foundation allowed us to use some of our remaining funding to say, well, let's just, not that we're saying that you would ever really dose valacyclovir at this high level chronically, but let's just ask the question, if you dose it the way you would for like zoster, 1.5 grams twice a day, and compare that to acyclovir 400 BID, which is what we've used in the Partners in Prevention trial, how much an effect could you get? And we were pleased to see that there was a dose response. That we got over a log reduction compared to baseline in plasma viral load in the valacyclovir arm, and about a 0.6 greater log reduction in the val arm compared to acyclovir. So it taught us something that, again, it's not kind of wish you knew this before you designed the trial, but that dose probably does matter. So this is the only study that's pushed the dose that much, and I think when you think about remaining questions, trying to see could you come down a little bit in the dose now that valacyclovir is generic and get somewhat close to this kind of reduction, maybe there would be both a disease progression and transmission benefit. So in our review, we showed the data on the various doses of valacyclovir, and it does appear that there is a dose response. And a gram twice daily study has just been published, and I think it's available online from Seattle, and they found not that much greater reduction than 500 twice daily. So maybe it's a rather steep dose response curve. And then I guess just to finish out the story about herpes and HIV co-infection, the RCI group recently published a study that looked at the same dose that we used in Partners in Prevention, which was 400 milligrams twice daily of acyclovir among people who had both HIV and herpes in a pretty narrow range of CD4 counts, 300 to 400. And they found a little higher reduction in disease progression than we did, about 27%. And they found that the benefit was greatest among people who had high baseline viral loads, where they found about a 40% reduction. So again, there's now 2 studies that I think are very consistent, saying that you can reduce delayed disease progression pre-ART, and I think it'll be interesting to see if the 2 studies there's any greater enthusiasm, and in this study with a little higher effect with the same dose, of thinking about herpes suppression to delay ART initiation. And how this got weirdly formatted, but this is a study that a colleague of ours in Seattle did with valacyclovir, 500 milligrams twice daily or placebo in women who were HIV and HSV dually infected and followed postpartum. And they found that not only did it a reduction in plasma, but also in breast milk HIV levels. So maybe there's also a benefit in terms of reducing mother-to-child transmission rates in women who don't want to stay on ART after delivery. So there are a couple of areas where I think there's still work to be done and potentially a role to target herpes. And I think there's also work to be done in terms of trying to understand why we're seeing this. Does herpes suppression actually reduce systemic T-cell activation? Peter Hunt at UCSF did a nice study and showed in HIV CMV co-infection that valganciclovir, which is a prodrug of ganciclovir, you did decrease CD8 activation. However, in the study that I just told you about in the Nairobi women where they had collected PBMCs, they found no effect of CD4 or CD8 activation on valacyclovir. So, I think there are only 2 studies that have looked at this. One could conclude, these are small. The CMV study was a very small study, but perhaps CMV is more important than herpes in terms of systemic immune activation. I think that's a question for which we don't know the answer yet. But then one last piece of the story that is kind of curious was that Bob Silicano's lab was looking at all sorts of drugs in a library of drugs to see, are there things that had been discarded in the past that might have activity against HIV? And he and a group at NIH, National Cancer Institute, both found that to everyone's surprise, that in vitro herpes, acyclovir and valacyclovir drugs appear to directly inhibit HIV. So it's curious. They use really high levels, but again, maybe that explains why we saw a much higher level of viral suppression in the high-dose valacyclovir. It's to really look at this, to see if this is true, you'd want to do a clinical trial in people who had HIV but neither herpes and HIV, and we tried to do that study in Seattle when we were able to find one person who met those criteria in a year. So it may be one of those questions that one can never answer in vivo. So I think there are remaining questions in this area, and in future studies, I wish in our study in Kenya we had collected PBMCs so that we could look at T-cell activation, but we were trying to be efficient and do a simple study. So you always kick yourself about something after a study, and this would be one. I think that there's some interesting questions to try to understand the mechanisms of action. There are new herpes drugs that are being tested in phase 2 studies right now that look to be quite potent, more potent than acyclovir and valacyclovir. So the helicase inhibitors, if those go through to market and pass through phase 3 trials, maybe those should be studied. And then I think to convince the skeptics that there's any role for herpes suppression for HIV disease progression study, I think we have work to do in terms of math modeling and cost-effectiveness analysis. So that's looking back at a decade of hard work and some disappointments, but a lot of lessons learned. And I think I want to just conclude the talk by thinking about what have we learned and where should we focus now. So that slide that I showed you with just the bacterial interventions showed the one Mwanza trial that showed an effect. Now we've added 3 others that really didn't reduce, the herpes trials did not reduce HIV acquisition or transmission. So not a great scorecard. And those trials, when they were published, had some interesting editorials, like by Ron Gray and Maria Waver, who tried to ask the question when we published our HPK-039 results, like, why is there this contradiction between the epi and the intervention trials? Is the hypothesis wrong? Is all this related to behavioral confounding and STIs are just a marker of high-risk behavior? or the intervention insufficient. And trying to address the issue of confounding in populations who acquire HIV because they're sexually active and therefore also get STIs is not easy. And you can do monthly follow-ups and collect tons of behavioral data, but it's hard to know that you've ever adjusted for all the right variables as well as you could. And a number of people have tried to look at the population attributable fraction of HIV due to STIs. And in the last year, there have been new studies coming out of southern Africa where still it looks like anywhere from 20 to as high as 40% on the high end for herpes of new HIV infections in young women are due to STIs. So the data, the EPI data do, in my opinion, still point to STIs as having an independent risk, but it's hard to really do these trials and to make sure that you're testing your hypothesis with a really potent intervention and have a large enough trial to get a clear answer. So this is a challenging area. And then Judy Wasserheit and I wrote a paper with Richard Hayes and colleagues from the London School and tried to look at all the data. And, I think we had somewhat different views on this, but, I think we have to say that one hypothesis is that we didn't use potent enough interventions in the herpes suppression trials. But there also are enough challenges with some of the smaller trials or trials that were done in populations with low STI prevalence that we are left with questions, so we don't have clear answers. But one could assume that if you're really going to target STI control for HIV, it sort of seems obvious that you should focus on populations where HIV is hitting populations rapidly. But that's not the case in most parts of the world. We're in mature epidemics most places. And my personal bias is that, and this will come up in the priorities I'll show you, that we have a lot more to do to understand the biology of how STIs influence the host response to inform our intervention. So Mike Cohen published in JID an editorial this year where he tried to put STIs back in the conversation because actually in the last few years there's been less enthusiasm for pursuing this line of research. People were disappointed. But I think he tried to use the same kind of language we use with pre-exposure, like prophylaxis, like are we targeting with the right drugs, the right assays, and at the right time in the right population. And I think that just to give you my concluding thoughts, I think that we need to look hard at new literature that's come out in the last 5 years about not just herpes, but also HPV, BV, trich. We need to continue to look for better interventions for herpes and BV. I think this has been a sobering lesson as an epidemiologist that observational data combined with biologic plausibility are not enough to establish causality. That the interventions may have an impact if we test more potent ones. That the data, as they've evolved, actually may suggest a bigger role for STIs and increased HIV infectiousness, but those are the hardest ones to test in clinical trials. And I think to keep you optimistic, it's important to remind you that, in my opinion, there still is a real paucity of data in some areas and an opportunity to contribute to research in an impactful way. So my 5 priorities are that it's a good time to review data now that we have several trials that have concluded with high HIV incidence and for which they collected good STI data, and to really look again in an epidemiologic way on the strength of the evidence and see how well we're convinced about some of the STIs that haven't really been tested in recent trials, HPV, BV, trich. But I think that when you really think about doing the intervention trials, you've got to focus on STIs that have good diagnostic assays that can be used in these settings without good laboratory support, and for which the interventions are scalable. And so trying to find an intersection where the attributable fraction is high, for which you have an STI with a good diagnostic assay and a scalable intervention, start getting down to a short list. secondly, I think we should not give up on looking for point-of-care STI diagnostics. Mike Cohen's commentary was written in the issue of JID that published these data from a trial in KwaZulu-Natal, South Africa, where they found that of women who had a clear vaginal pathogen, only about 12% had any signs or symptoms. So, and I didn't put it on the slide, but they also showed for those that had symptoms, a small proportion had a pathogen. So the sensitivity and specificity of syndromic STI management is just not good enough, and that we need better diagnostic assays because these vaginitis is very common, and we do very poorly at treating it. And this study and multiple others that I've shown you suggest that vaginitis is an independent risk factor for HIV. Third priority is just we need to move from thinking about STIs on a pathogen-by-pathogen basis. And I think I know Jeannie Marazzo was here in June, and I think our understanding of BV is it's not just lactobacillus up, down, but it's about bacterial communities. And that makes it much more challenging to study, but that is the reality, probably, and that we need to think much more holistically, if you will, about STIs, either as a syndrome like BV, but also in how they interact. And there are some interesting observations that I think we need to not forget about how bacterial vaginosis impacts risk of herpes acquisition, how herpes influences the ability to treat BV, and we have recently had a paper suggesting that BV increases HIV set point in women who became infected. So it's complex. And part of why it's probably complex is that we shouldn't just think about the pathogen, but about the immune response. And I showed you the data on herpes and persistent genital inflammation. Recently, the Caprisa group had data from the tenofovir trial where they showed that innate immune activation seems to increase HIV acquisition risk. And perhaps some of that's triggered by STIs, but trying to make sense of this area is complex. There's a lot of noise with studies that look at cytokines, so I think that we really need very rigorous immunologic work to try to make sense of the host immune response, both innate and acquired to STDs. And then lastly, I'll just finish and talk about STDs as part of combination prevention, an area that I've become increasingly interested in. We now have tools that do work, be it treatment as prevention, pre-exposure prophylaxis, male circumcision. And we have to use those tools very smartly to get high coverage for populations at risk. And where do STIs fit into that? We have that one study from Rwanda that suggests that maybe there should be an impact and an intervention related to STIs. But we're really, I think, not sure about how to move from those old data in Rwanda to current interventions. So combination prevention currently is focusing very much on scaling up male circumcision, getting people to know their status, accompanied by behavioral interventions, condom distribution. We're waiting for the confirmatory trials with tenofovir gel. We've now had 3 studies that had moderate to high efficacy of oral Truvada, and one old study looking at some impact of post-exposure prophylaxis, and the very exciting evidence that treating the infected partner has a very profound effect on infectiousness if they can achieve viral suppression. So we have all these tools right now, but we really have to put it together in a smart way to get high coverage to get the maximum impact. And I think where STIs fit in that is an area where we're all scratching our heads right now and need to be very smart about it. So the real question, I think, is which STIs to target and with which interventions in which populations. And hopefully the next generation of research in this area will give us guidance there. So just my concluding slide is just one that this has not been a straightforward process, going from what seemed like such consistent data a decade ago for herpes and HIV. I had to learn the hard way that Epi doesn't necessarily predict the outcome of clinical trials, but I think that I would like to say that I think that these are important questions. They continue to engage me, and I hope that you. It's really an incredible opportunity in one's life to ask questions that have big public health impact. To do it, you have to work with people you respect and enjoy. Never say die, and keep at it. There's so much to learn and do. It's not a straight road, but it's a road worth walking. I like to cite a quote from Nelson Mandela, who, of all people, knew that there's always another hill to climb, and we'll climb it together. And just want to thank the people who've walked that road with me. And I think I've also learned the value and the truth in this proverb from Africa that if you want to go fast, go alone. If you want to go far, go together. These trials are hugely difficult, expensive, but you learn a lot in the process. And it's been a real incredible opportunity to walk that road with people I enjoy. And that's the last PowerPoint. Thank you. So do we have time for questions? Oh, no, Kim, you can't ask a hard question.
So this is a question I've been thinking a lot about in regard to treatment of herpes. Is there any role at this point in your mind for episodic therapy for people that got diagnosed with herpes? And I'm talking about symptomatic herpes, not screening asymptomatic individuals and putting them on an antiviral. But do you see any role with the emerging data, and herpes is always on, that there's ever any reason to put anybody on any episodic therapy versus suppressive?
Yeah.
And number two, with knowing what we know about pharmacokinetics in terms of valacyclovir, is there and it's generic, is there any role for acyclovir anymore?
Good question. But you're asking specifically for HIV benefits? Yeah, I didn't show that slide, so I'm glad you asked the question. There were three, for those who didn't follow this field, there were three trials that asked the question about episodic herpes treatment. And the bottom line is that it was too little, too late. Because people would come in, and these were studies using standard doses of acyclovir for about a week to people who had HIV and genital ulcer disease due to herpes. And basically it shortened the duration of an ulcer by a day and did not reduce viral load across the three trials. So I thought that was, I guess someone needed to ask that question in those trials, but I wasn't at all surprised by the results. They've come in with an ulcer that's been present, that's caused immune activation for at least a week, probably longer, but as it was becoming more symptomatic. So I think that if you're going to do anything about herpes, you should put them on suppressive therapy. I do think that there was a consultation at WHO about this where we debated it a lot. And I think for the reason for keeping any role for episodic treatment is that the people who do have symptoms who come to a STD clinic or another type of clinic, you don't want to just tell them we can't do anything for you. But I think if you can use that as an entry point to start them on suppressive therapy, so start with episodic and then transition to suppressive therapy, that makes the most sense to me. And I think in terms of VAL versus acyclovir, there are data emerging that even VAL isn't as good as we'd like it to be in terms of suppressing herpes reactivation, and it's not that different from acyclovir, but since it is generic and you can a little more forgiving of doses, I think it makes more sense. But it's interesting. I think there's in the New York Times an article about generic drug policy in the U.S., and when I write a script for VAL, I'm struck by how expensive it still is compared to acyclovir. So for some settings, that cost difference is enough that they're not going to make it on the formulary. So I think that's a whole other conversation. We need to do something about generic drugs in the U.S.
Operator?
Thank you. On the phone lines, if you have any questions, please press star one. Again, that's star one for any questions.
Okay.
Connie, that was really nice. A really nice summary of a lot of data. I have been really interested in this tenofovir finding, and I'm wondering if you could fill us in as far as what the mechanism of action would be and sort of perhaps maybe some of what's going to be looked at.
Okay. So tenofovir is in the same family as adefovir, which has some herpes activity, and they never really expected at the doses you would give orally that it would have an effect on herpes suppression. But I think if you look at the CAPRISA data where they looked at tenofovir levels in the vagina, it was like 1,000-fold higher than the MIC for herpes. So when dosed in the with a gel as opposed to a pill, you're getting such high levels that you exceed the MIC. But I also think there's some probably lessons here that when you think about what drug level you need to aim for prevention as opposed to suppression, that we may need a lower dose. So I think stay tuned for additional data on tenofovir and herpes. I think there'll be some interesting observations. So, and one of the questions we also want to ask is whether or not, since tenofovir is 90% of people who are on ART or on a tenofovir regimen, have we had an impact on reducing HSV2 acquisition in HIV-infected persons? So we're trying to look at that as well.
Thank you so very much.
You're welcome.
I'd like to say, if you would like to have a more intimate, smaller space, back and forth interactive discussion with me, please join us at 1:30 in Building 11, Room 2214. Connie has kindly agreed to do that. Right. Thank you so very much. That was outstanding.